3 things I would never do as an infectious disease neonatologist.
I avoid the buffet in winter. Sorry.
Okay, yeah. Is it possible to be a germaphobe as an infectious disease doctor?
I think germs is a derogatory term for bacteria.
Hi, welcome to The Vitals, the Mount Sinai Health System's newest video podcast. I'm your host, Leslie Schlachter, a neurosurgery physician assistant here at the Mount Sinai Hospital. Today, we're talking about the viral lung infection RSV, Respiratory Syncytial Virus. It's a common infection that affects the lungs, often in children. I'm so happy to have Dr. Shan Liu, Associate Professor of Infectious Disease, and Dr. Jennifer Duchon, Associate Professor in Newborn Medicine and Pediatric Infectious Disease. So thank you guys so much for being here today. So you guys generally do the same thing, infectious disease, but you focus on children and you focus on adults, correct?
Correct.
Yep.
Okay. Why don't you tell us a little bit before we get going about your practice? Like, what does a typical day look like for you?
My day's a little bit odd. I like to say that I sit on many horses with one ass. I'm also the pediatric hospital epidemiologist and director of antimicrobial stewardship. So I spend a significant portion of my day actually dealing with the epidemiology of the hospital, making sure that our patients are safe, that everyone's on contact isolation, and that there are no real issues.
So you're like the rule follower person.
I'm also a little bit of the rule enforcer.
Mm-hmm.
So that occupies a big proportion of my day. When I do in ID service, I ran with our fellows and we do our regular patient care. We do consults on the floor, consults in the ED. And then sort of my other life is when I practice neonatology, which I really love. I'm a clinical neonatologist as well, so I'll go and just do a lot of hands-on patient care in the ICU, in the neonatal ICU, which I really enjoy.
So you, like while you were kind of introducing what you do, you said ID, just so for our listeners, that's infectious disease.
Yeah. Right. Slang,
Yeah. And in medicine, we use a lot of acronyms, and everyone always assumes everyone knows what it means, but it turns out not everyone does. But ID, everyone in a hospital should know.
However, the NICU is probably a different place for me than it is for you, because NICU is neonatal ICU.
Right. So ours is an NSICU, neurosurgical intensive care unit. Okay. So we either call it neurocritical care or NSICU, neurosurgical. Yes. Good to know. But at the beginning, there's still probably 1 to 2 people a week that get that confused and go to the wrong ICU.
Yeah. We occasionally get calls that are not appropriate.
And what about you? Do you see patients in the hospital, in the outpatient setting?
I'm also one button, multiple horses, I guess, or what was it saying?
Something about a horse's ass?
Yeah. I mostly do research. I'm medical director of the COVID clinical trials unit. So when COVID happened, I kind of helped lead a lot of clinical trials during that time. A chunk of me does patient care, clinical care, and
inpatient or outpatient?
Inpatient clinical care. Adult infectious disease consultation service, and then a small fraction of me does lab work. So I'm a mixture of MD, PhD, what they call the translating type. I bridge research into people. Yeah.
What do the letters underneath your name mean? CTRC.
The CTRC is the Clinical Translational Research Center, which is a research unit in Mount Sinai that's devoted to infectious diseases, and that does. The COVID Clinical Trials Unit is a subset of the CTRC, and a lot of people don't realize this, but there are several different types of research units scattered throughout Mount Sinai in our system. There's the CTRC, there's the MCTO, the Medical Clinical Trials Office.
You don't even know your own acronyms.
The Medicine Clinical Trials Office. There's the CRU, which is the Clinical Research Unit, which is the Dean's Unit. Okay. And then there's Neurosurgery has its own research unit. Hematology Oncology has a research unit. And there's several other research units out there. The CTRC is one of these research units that I'm part of.
Okay. Well, we're here today to talk about RSV. And what I kind of find interesting is, like in social media or out there in the world, people are talking about like, what's this new RSV, this new thing that's happening, and everyone in healthcare is like, this is not new. But people are talking about it now. So let's start off with, what is RSV?
So worldwide, it's one of the most common causes of childhood pneumonia. also in the US. It's a seasonal respiratory virus, at least in the Northeast, that primarily affects the extremes of age. So just as a little bit of background, I think that one of the reasons that we're talking about it, of course, like you said, we all knew about it beforehand, but due to many of the non-pharmacologic interventions for COVID, we had a season that was functionally without a lot of respiratory viruses. That was 2021, basically 2021. When we all started to go back to work and to school, we saw a little bit of a respiratory viral seasonal peak, which we typically do, of which RSV is a component of that. And when everything sort of reopened in 2022, we had the triple-demic, and that made the news. And I think that's when the public really started to realize what RSV was, because that was considered part of the triple-demic. Everyone knew about flu, everyone knew about COVID,
right?
But RSV was all of a sudden in the mix. So it's a seasonal respiratory virus that hits usually in pediatrics, and again, it's seasonal depending on where you live in the world. In the Northeast, we see it around when school starts.
Cold season.
Like cold season, October to March. We actually do really have a very defined season for it, though, because we do our pharmacologic interventions and preventative interventions based on a season. And so, it's one of the respiratory viruses.
Okay, so it's a virus. So when patients say, I want some antibiotics, I think I have RSV, we kind of giggle a little bit.
Yeah, we're like, no.
So what are the signs and symptoms of RSV, and how do they differ from other typical viruses?
That's a very good question. I think so RSV, I see it as again, respiratory syncytial virus. It's a virus. It's, in my mind, always like the common cold. Like there were coronaviruses before COVID-19, and so that was one of the common cold viruses. RSV was one of these common cold viruses, and influenza was one of these common cold viruses. They all kind of present a little bit differently, but overall, if you have like a runny nose, cough, fever, just common cold symptoms are kind of like the generic way to think, hey, maybe I have RSV, or maybe I have a coronavirus, or maybe I have flu, but the flu is a little more fever and body aches, but RSV is more like a respiratory focused thing. Yeah.
How does it progress to the point where let's specifically talk about children, where it's not just a common cold, you can manage it at home? How do the symptoms progress where parents would seek help for their children?
So RSV is interesting because we believe it has some long-term implications as well, and it has implications based on age. So it really can cause very severe disease, not just the common cold, in the tiniest of infants. So of about 1.4 million infections, the majority of hospitalizations occur in infants who are less than a year. And really in the first month of life is when the disease is most severe. So an infant may have a sibling who's in daycare, they just get a common cold. You or I just get a common cold. But for little ones, it really affects the lining of the lung, and it can constrict the airways such that they can have difficulty breathing.
What does that sound like?
So in some cases it sounds like wheezing. In some cases they just will have a very bad cough. Almost all of them also have upper respiratory symptoms. Babies, interestingly, are obligate nose breathers before a certain age. So when their noses get congested, they can have much more difficulty breathing. And if it's affecting their lower respiratory tract as well, they can really get in very severe trouble very quickly.
So if it's kind of leading towards the danger zone, will the parents hear it in like how they're coughing or breathing, or are they going to like start looking blue? Yeah,
so what we usually advise is look at their breathing. So many babies will have what we call retractions, meaning their chest will move in a little bit when they breathe. They may breathe very fast. If they're really blue, then that's a much more worrisome and later sign. So we sort of first start to look at what their breathing pattern is, and how hard they're working to breathe.
One of the things that happened during COVID, I mean, I know I did and all of my friends did, is that people bought pulse oximeters. So a lot of people have them at home and they would check it just, you know, if they had a fever and had COVID, they watch it and they wait for that number. Is that something that you would recommend parents having for their children and checking that, or is that?
Yeah, no, not at all. In fact, the American Academy of Pediatrics kind of formally recommends against those. They can have a lot of signal to noise ratio or be very distracting.
Like artifactually poor.
Yeah, and in babies it's very hard too because they're not really well validated. Babies move around a lot, so keeping them on is hard. Really also some of the difficulty with RSV is that babies will breathe too fast to be able to intake food properly. If they're feeding through a bottle, they have to suck. If their noses are congested, they often can't breathe. Or again, just sort of the work of breathing makes them very tired, so they're not able to do their normal activities. So that's kind of a secondary risk of having the virus besides just having the symptoms themselves.
Is it the same thing? So you said like extremes. Is it the same thing for like the geriatric population? What RSV looks like?
Yeah, it's it's pretty dangerous for adults who are above the age of, I believe, 60, 65 and older. If you have other comorbid conditions like a lot of our population at that age does, you have things like COPD or chronic obstructive pulmonary disease, you have CHF or congestive heart failure, you have chronic asthma, you're in the smoker category. It's dangerous. And actually there was a really interesting recent paper looking at what happens to people who have an RSV infection. And they found that within 28 days, 1 out of every 20 people will get hospitalized after having an RSV infection if you're at that high risk category. And so RSV is very, even though you may not have heard about it until recently, it's something to keep on your radar and to be aware that this is something
But why does it happen? Is it that the virus itself is leading to just, like you said, like a pneumonia situation, or is it leading to like a restrictive lung disease with scarring? What's the reason for?
It's thought to be sort of like an inflammation or bronchiolitis or a pneumonia or a lung infection, and those two things can trigger off or set off a person who is at baseline weakened and then kind of like push them over the edge a little bit, and then a lot of those people need to get hospitalized. Yeah.
So people who are immunocompromised, old and very young are just not strong enough sometimes to handle.
Or have lung disease or heart disease, yeah, which is a lot of people. Yeah, and I've actually seen firsthand when I was taking care of people a few years ago. I saw older gentlemen get pushed over the edge, get hospitalized, and then we're like, oh, why is he having such terrible heart failure? We tested, he ended up having RSV. You know, it really can push your heart failure or COPD to a hospitalization severity. Yeah.
You had mentioned that during COVID, it kind of like talking about RSV kind of dropped down, and you said non-pharmacological measures. I took that as like hand hygiene, masks, things like that. Yeah. So how is RSV spread, and what do we use to prevent it? Like masks, cleaning?
So when patients come into the hospital, we put them on contact isolation. So RSV is kind of spread by droplets that don't stay in the air. So it's not really respiratory spread per se. It's more these kind of large droplets that fall onto surfaces.
Or like sneezing into my hands and then shaking someone's hand.
Exactly. So a lot of it is hand to mucous membrane, or those kind of viruses, like many of the other common cold viruses, can stay on surfaces for a while. So good hand hygiene, staying home when you're sick. So not really being in close proximity to people.
Right.
Unfortunately, which
it's
is
hard
really
in New York
because
people ride buses and subways, they touch things. Yeah. You have good intentions of maybe alcohol in your hand, but do alcohol-based sanitizers work for RSV, or is this like a hand washing thing? They
do. They absolutely do.
Okay. What is it? Is it norovirus that doesn't respond to alcohol sanitizers?
Yeah, norovirus and Clostridium difficile are the ones that we really recommend that people
like the hand wash
need to get the spores off of. No, this is fine with your common hand hygiene products. It's great with hand washing. You know, one of the difficulties that we face is that in families, again, it's seasonal. It's a common cold. Little kids in daycare get common colds every 20 minutes, and they bring it home to their younger siblings. RSV specifically, you don't get lasting immunity from it. So you can get the virus more than once in a season, and you get it.
How long do you have immunity from it?
So it's not particularly long lasting. We think it lasts a few months, depending on how you make your immune response to it. We know that if babies get it a second time in a 6-month or so season, the second time they get it is not as severe at all. So they have
like
some
a little
antibodies.
immunity.
Yeah, but it's not lasting. So the next year they can get it again. The year after that, they'll get it again. Right. Again, you can get it interseasonally. It's just not as severe when they get to be, again, definitely more than a year, but absolutely more than a month or so.
Okay, let's talk about the treatment for it. We know that with bacterial infections, people give antibiotics, or fungal infections, but are there antivirals? How do you, a sick adult comes in, CHF, gets RSV, they're not doing well, what are the treatments?
Really, it's supportive.
Yeah.
There's one antiviral that we used to use, ribavirin. You can give it inhaled. I believe you can give it maybe PO or IV. There is a systemic form. It's a pain in the butt to give.
Yeah, we don't.
Yeah, you have to. You're not supposed to use it around pregnant women. It's a huge volume. There are a lot of rules. It's hard to get. It's costly.
And does it even work well?
I know that the patients that I've used it in have been transplant patients, older transplant patients. In little kids, it's not even considered really on the table.
All right, so this is like a very important part of the conversation.
Oh gosh.
Because when patients come in, they want to be treated for their illness. So treatment to non-healthcare people, that usually means like, give me antibiotics, give me a pill to make me feel better. But supportive care is also treatment. It just might not be like an antibiotic or something. So let's talk about what supportive care for RSV means.
Before we talk about supportive care, I want to mention that we're actually actively enrolling for a study for outpatient RSV treatment. And so COVID came along, and then remdesivir is a antiviral used for COVID.
What's Tamiflu for the flu?
Tamiflu.
Yeah, Tamiflu, but is there like a generic name?
Oseltamivir.
Yeah.
Okay. So like that kind of thing?
Yeah.
Where like you take it and it like shortens the course or something?
That's the theory, and they're considering an oral version of remdesivir called obeldesivir, which is we're testing to see if there's a treatment for that for RSV, and there's some preclinical data to suggest that it may be helpful. Yeah.
So we have clinical trials for that here at Mount Sinai?
Yeah, we do. We have a lot of clinical trials, and we run a lot of interesting things, but we need to talk more about those, I guess.
Okay.
Yeah.
All right. So we can find a way of getting that information and putting it down below, because people watching this, I mean, RSV is really common. I want them to be able to like see a number or a link to click on if they want to participate.
We can provide that link.
Okay, cool. So let's go to supportive care. How are you treating patients that come in and they're really sick from RSV? How do you help them get better?
I think the most important thing is to make sure that their oxygen level is sufficient, and then, like you said before, measuring their pulse oximeter and seeing whether they need supplemental oxygen. I think that's number one.
So like either oxygen via nasal cannula or like a BiPAP machine.
Yeah, I think that's what we should stress, in the sense that if you're in my situation, I guess, an elderly person, you're having a lot of trouble breathing suddenly, you felt a little bit feverish, you should go get checked out and see, hey, you suddenly find that your oxygen's like 88 or something when it should be 100. Then you should see a physician. They may recommend you to go to the hospital and then get supplemental oxygen, so you stay above 90, 92, you know? And I think that's very important to emphasize.
So people at home, so babies, we said no to the pulse oximeters, but the adults, they have their pulse oximeters from COVID. They put their pulse oximeter on. What number are you saying you should probably come in?
I usually, I'm not saying you should always keep a pulse oximeter on at home, but I think if you're having trouble breathing, you should see a doctor. But if you do have a pulse oximeter at home and you're checking yourself out and you see that, my oxygen level is normally 95 to 100, somewhere around there. Right. And now it's dropped down to below 90. It's like 88, 87, 86, something like that. Yeah. You should go see somebody immediately. Okay. Yeah. Okay. That's something has changed. And you may need supportive care.
So oxygen?
Oxygen.
What about like bronchodilators or steroids or anything like that?
I think that kind of goes into a detail of like you need to examine the person, see if they're wheezing, see if their lungs are tight, and then probably bronchodilators if that's necessary. But oxygen is your vital.
That's the key.
That's the key. That's my impression.
Yeah, for babies and children, it's a little bit different. They can certainly get hypoxic. They can certainly need oxygen. Sometimes, especially babies, need either CPAP or some other form of invasive or non-invasive ventilation to help keep their lungs open, because again, there's a lot of inflammation going on and the airways sort of become smaller with that inflammation. Babies and children often need IV fluids because they're just not able to eat as well when they're breathing so fast, or they just may not feel well and get dehydrated, which little tiny babies can get pretty quickly. What other supports are there? That's pretty much it. In terms of bronchodilators, for pediatrics, we will occasionally give them. Bronchiolitis in general, and RSV specifically, definitely causes patients to wheeze. Whether that wheezing is necessarily responsive to bronchodilators is kind of an entire topic in and of itself.
Well, you guys said that RSV causes more of like an inflammation rather than like a spasm.
Yeah,
right?
exactly.
Okay.
So the end result can sometimes be the same. And some patients can benefit from bronchodilators. That's one thing that we also think about in children, is that there's some literature associating early RSV infection with later wheezing episodes, and not really sure whether that's chicken or egg, whether having RSV makes you wheeze later on, or or do you get symptomatic RSV more frequently because you're going to be someone who already has an underlying predisposition to having a wheezing illness or wheezing.
Is there a vaccine for RSV?
That's my favorite topic.
Yes, it's
my God,
hot
I'm so
topic.
happy.
Yeah.
Tell me about the vaccine.
Do you want to talk about the kids side, and I'll talk about the adult side?
So concurrently, 2022 was a terrible respiratory viral season, and definitely RSV was a big component of that. And already in the works were both a vaccine and a monoclonal antibody. So we already kind of had in the works two preventative strategies that were rolled out in 2023. So we had those in theory available for the 2023-2024 RSV season. So for kids, for babies, there are two strategies. So there's a monoclonal antibody product called nirsevimab. There was already a monoclonal antibody, so basically not a vaccine. We call it an immunization because you can have passive or active immunization. This is passive immunization. We're giving you the antibody. There was a product that was available for the very highest of risk infants that was very expensive.
Like preemies?
Like preemies, and only really approved for use in a certain tiny preemies. And you had to give a shot every month throughout the RSV season, and it worked okay, but not great. Then the second generation nirsevimab is a monoclonal antibody product that has about a 50-fold increase in what we call neutralization properties. So it binds the virus and prevents it from doing its job, which is basically invading the epithelial cells and causing them to fuse. That's what the syncytia are, and causing inflammation and cell damage. So this product prevents RSV from doing that. And it's given standard of care now, or I should say the recommendations are that all newborns get it. So we tried to roll that out in 2023. Everyone was very excited about it, and the product just wasn't. They didn't anticipate
they weren't ready.
Weren't ready for it.
Right.
And the rollout was a little bit of a disaster. This season, it's definitely one of our top preventative strategies. We have sufficient supply. We're, as a hospital, giving it to every eligible patient. The recommendations are that babies get it within the first week of birth. And if they're tiny preemies, about a week before they go home, or as close to discharge from a hospital if they have a prolonged birth hospitalization.
Have you seen, like this year, this season? Have you seen a dramatic improvement in like admissions?
Yeah,
readmissions?
it's hard to say. We're tracking that data now, and when you look at the CDC's data, what we see is in the less than 6-month-olds, there doesn't seem to be as high an incidence at all. It seems to be about half the peak of what it was last season. However, in older kids, it seems to be about the same. So we hope so. We'll have a lot more data. This particular product, the original trials, as well as the first season data that we had from last year, showed that there's probably about 75% efficacy in preventing severe disease and hospitalizations in
That's
babies.
a big deal.
Yeah,
Yeah.
it is a big deal.
Is it similar in adults?
They don't have nirsevimab.
Yeah, we don't.
Right?
What do
we
you
don't
have?
There's a vaccine. There are 3 different licensed vaccines for RSV. They're focused on people. I think it's recommended for everybody of the age greater than 65, or if you're, I believe, the age of 50 to 65 and have some of these comorbid conditions, then you should take it. It's not a seasonal vaccine like flu or now COVID, I guess, is kind of considered a seasonal vaccine. And so it's kind of a one-time thing, and it seems to prevent severe disease, which is what vaccines are meant to do.
It's recommended for that age group period across the board, or just those at risk?
65 and above,
Okay.
everybody. Yeah.
Okay.
And we also, so concurrently to those vaccines coming out, there were also vaccine trials for moms.
Correct.
Because another strategy is to vaccinate a mom,
Right.
have her produce the antibodies, pass those antibodies on to the baby. There are a lot of vaccines in pregnancy that we give exactly with that intent, like the Tdap,
Right.
pertussis. So that was another strategy. And there's one vaccine that's approved for use in moms to prevent RSV in the babies. The efficacy is about the same. There are some limitations in that moms who give birth early may not have may not have passed on enough antibodies to the baby, or if they got the vaccine too close to when the baby was born, they won't have sufficient antibody production to pass on. But that's also an option, and the official recommendations are that when a mom's pregnant, you present her these 2 options, and basically shared decision making. Moms are eligible to make either of those decisions.
Are there any other treatments or vaccines or anything on the horizon for RSV that we should know about?
Clinical trial.
As clinical trials?
Yeah, clinical trials. Like I said, abaldesivir, which is an oral version of remdesivir, is being tested out right now, and we're looking to enroll participants who think they may have some sort of upper respiratory cold, and then we'll come and test you, see if you have RSV. If you do, then we'll see if you fit our eligibility criteria. It's a 5-day oral course, and we kind of follow you out for a few weeks and see how you do.
You have to see them when they're sick. Like when they feel sick, they need to get in.
If they feel cold-like symptoms, cough, feverish, runny nose.
I feel like you should have a line outside that, like at this time of year.
You would think. You would think. It's very hard to recruit for clinical trials. Yeah, people are scared, and rightfully so. I mean, it's you're putting your body to receive some treatment that hasn't been shown to be efficacious, but this is a phase 3 study, so they're looking to see if it's effective in treating the disease. But it has passed phase 1 and phase 2, which shows that it's safe to move on to a phase 3 study. So, but people, when they hear clinical trials, usually the response I get is, "Do you want me to be like a guinea pig?"
So what you're saying is it might not work so well, but it's not going to hurt you.
From the data we have, the data suggests that it's safe enough to administer to the next round of people, and that's kind of how science advances,
Right.
And I think that there needs to be more understanding about how clinical trials work and the progress and the kind of investment of the community to participate, to have more treatment options. Otherwise, there really isn't an outpatient treatment option for RSV.
Yeah.
So you're saying Dayquil and NyQuil don't count?
Dayquil and NyQuil provide symptomatic relief, but if you really want to hone in on RSV and stop that virus, we need these kind of
Right.
clinical trials.
Right.
Yeah.
What are some of the most common misconceptions about like cold and flu season?
I guess if you're my mom, then you would say, "Oh, go get some chicken soup," and that'll cure you. Or the second misconception is that, "Oh, you should stay out of the cold because that's
a big.
So
That's a
don't,
mom
that
thing.
don't go out.
Right.
Don't go out in the cold
It's
weather with a
definitely
wet
a
head.
mom thing. Exactly.
So that's not a thing, right?
Not a thing.
That's
No.
I think I've seen some random. I forgot when. There's some studies where they put people in refrigerators
Yeah.
to see if they have a higher chance of developing cold, and there's no
Oh, I
difference
would not
between
want. I
keeping
want to
them
be in the controlled
chilled
group.
versus
No.
they're so that's a misconception.
Okay, so you can go in the cold with a wet head.
Yeah.
Chicken soup isn't
Not recommended,
right.
but-
But chicken soup does not work
Well,
There-
it's
there's no-
symptomatic.
It might make you
relief.
feel better.
It makes you feel better because
because I'm a Jewish mom and I
Yeah.
believe that chicken soup works.
So there is a little bit of data on chicken soup because it's a warm fluid that can loosen secretions
Right.
and
It
sort
can
of
also
make you
keep you
feel better.
hydrated and give you electrolytes.
Exactly. How much salt? I'm not quite sure, but yeah, absolutely. But again, that's not. We don't have the randomized control trial. You're not doing that in the CTRC.
No, chicken soup.
Chicken
No,
soup
no.
trial?
It's hard to.
I will enroll in
Everyone's
that.
chicken
Okay,
soup is
there you go.
different, so it's very, very hard to control for chicken
Yeah.
soup. Yeah. I think I hate to bring that topic up, but the question of whether vaccines work or not,
Right.
and the harm versus good, I think that's something that we should all talk about, and it's very important in our community to really appreciate that vaccines that your immune system is. I always see your immune system as like a student. You know, it's a learning organ of your body, and then if you don't, if a pathogen or like a virus or a bacteria come up to your body and kind of beat you up, right? You're going to get sick, and you're going to go. You might get really sick. You might get okay sick and get over it, but you didn't have that protection. A vaccine, the way I tell people is, it's kind of like, you've given your immune system a training course, and like, okay, when this bad guy comes into my body, how do I defend against?
It's learning
this?
a chokehold.
It's learning a chokehold. It's learning self-defense, right?
Mhm.
So, and on top of that, like, the more times you educate your immune system or teach it or remind it to do how to manage this, it gets better and better each time. So it's important not to just get like during COVID, everyone got one vaccine and they're like, no, I'm done. But it's good to train your immune system and keep it in shape. And a lot of times there's seasonal vaccines. Why do I need a seasonal vaccine? Well, your immune system kind of like wanes after
Right.
a few months, and then you may need to remind it, this is how I protect myself against flu. And so that's the real purpose of vaccines. It really keeps your immune system martial arts in check, and it keeps it sharp.
So what
you're
is the
prepared.
public
Yeah.
service announcement for that? Because like we all know now, with everyone generally, especially if you work in a hospital, you get your flu shot once a year, right? You're supposed to.
Yeah.
If not, you have to wear a mask. What is the rule for vaccines for COVID? Because like nobody's really talking about that anymore. What's the recommendation?
The recommendation is everybody should get a booster. That's the recommendation, the federal recommendation.
Yeah, it's not necessarily a booster, just like you pointed out with the flu vaccine. It's seasonal now. In the beginning, the COVID vaccines were actually, we figured you had to have a series of them to actually get your immunity up. And in children, you do that with the flu for the very first time.
Right.
They're vaccinated below 6 months of age. But now we're responding the same way we do to flu with different strains. There are different strains of COVID. And so we're providing vaccines that have updated coverage to new strains. That's true with flu as well. So your yearly flu vaccine covers different strains than it did the year before. So it's important to get those updated.
And to
Yeah.
carry on that point, it's to remember that viruses are evolutionarily light times more powerful and evolving than we are. They're
Yeah.
like replicating millions and
very smart.
millions and millions of times per minute, you know, and it's like spewing with different variations of itself. So it's like a population of viruses that's constantly trying to change itself, and the replication is not perfect, and so it keeps on coming with new antigens and little proteins and everything's kind of,
Yeah.
I always say it's like the bad guy that kind of like puts a new mask on or changes its face slightly. So your immune system, if it's not aware of like, hey, what does this guy look, or what does this bad person look like now, it may not be as effective as it should be. And so that's why these updates, I think, especially in people who are at high risk for severe disease, like those elderly populations and people who have immunocompromising populations, those people really should think about and consider vaccines, even if it is a recommendation. Recommendation doesn't mean it's the law. It's like, hey, you probably should get a vaccine. I strongly suggest for that population of people, you really should think about getting a vaccine, because even this season, our hospitals has a lot of influenza.
It does.
And I'm seeing patients and I ask them, hey, did you get the vaccine this year? And they're like,
it doesn't work for me.
I couldn't. And then I'm like, oh man, this could have been prevented. You know? Or maybe it would have been less severe.
Less severe, I think.
Less severe.
So I was telling you guys before, I'm a surgical PA.
Yeah.
And so one of the things for me in neurosurgery specifically is there's about a 3% risk of a postoperative infection after neurosurgery, which means I'm worried about like a wound infection or meningitis or an abscess or something. If I have a patient during cold and flu season and a week after surgery they have 103 fever and feel terrible, I have no choice but to readmit them and work them up for a post-op infection. When in fact it's probably cold, flu, like COVID, RSV. Yeah. I just saw a patient today. She's a week and a half post-op. She's at home with her son who has the flu. Neither of them have a mask on, and I'm like, are you kidding me? Like, you're giving me, like, it makes me nervous. So my instructions preoperatively for anyone that has surgery between like September and March, get your vaccines. Please get your vaccines, because it, like, even if you are going to get the flu, maybe it's just not going to be so bad. So I really hone in on that because it just makes me really scared because I won't know what's what sometimes.
Yeah, especially for neurosurgery patients, they're probably immobilized in some level or like.
Not my patients. They're all perfect.
Okay. Who do you do surgery with?
But it makes me nervous. Vaccines.
Yeah. I think vaccines are.
Yes. Yeah. A common misconception in vaccines is that people want their bodies to work and fight for themselves. They don't want vaccines tricking their body. What do you say to?
I agree, and I actually agree with them. I think if you're a regular healthy person, your immune system your immune system's natural response to a natural infection is probably a better training in a sense because you're actually fighting that real pathogen or virus or bacteria head on, right? But you have to really think about what's the cost of that training. Like, can I get really sick? And a lot of people really get sick. So especially if you're at high risk for going to get hospitalized, you're elderly, you're immunocompromised, don't go through that because you can actually get sick enough to die, right? And then then the vaccine could have prevented that from happening. It's very important to really think about. And the other point I like to bring up is that when you get vaccinated, you're not just helping yourself, you're helping your community, right? You're helping your elderly father, your elderly mother, your little kid, your cousin who's immunocompromised, your neighbor who's got COPD. You're preventing, or you're limiting your disease, and you're charging up your immune system to fight that virus more quickly, so that it doesn't spread to the people you love. And a lot of people keep forgetting that. Oh yeah.
Let's close up with a fun game because this is kind of a trend on social media. If you think you can go first, you can go first. Doesn't matter.
Scary. Okay.
3 things that you're going to start off with. 3 things I would never do as an infectious disease, neonatologist. Right? One of them might be I will never not get a vaccine.
Yeah, fair enough.
That might be one of them.
Okay. So 3 things that as an infectious disease physician and neonatologist I would never do. I would never not get a recommended vaccine. I get all my vaccines. I make my husband get all our vaccines. So number 2, I personally, don't touch my eyes or my mouth or my nose without having washed my hands first.
That's so hard.
It's really
hard. What about
hard.
if you're home in your own home environment?
I feel like this phone is a wonderful device that when we sometimes just for fun do what we call ATP testing, so when we scan it to see how many gross DNA particles are on it, this is just terribly contaminated and we touch it 10 times a day. We carry stuff in our shoes, we carry stuff in our bags. So no, I try not to.
It's like a petri dish, huh?
It's a petri dish, and remember, viruses can live on surfaces for a long time.
All right, what's number 3?
What's number 3? Avoid the buffet in winter. Sorry.
Okay, yeah.
Yeah. Sorry. It's not only respiratory viruses.
You don't have to apologize to us. It's not our buffet.
I mean, I know, but I do love a good buffet.
Yeah.
But it's just... There's
That's
just
reasonable.
so many risk factors.
Is it possible to be a germaphobe as an infectious disease doctor, or by default are you just germaphobes? Or do you welcome germs?
I think germaphobe is a really, I think it's kind of a tough word. I don't consider myself a germaphobe. I think germs is a derogatory term for bacteria.
Germs is insulting them. I mean,
that's what society calls it. They call them germaphobes.
It's true, but they do live among us.
Exactly.
Right? We need a good commensal flora
exactly.
to be healthy. We love
That's how
them
I feel too.
Under the
we
right
like
context.
them if they're doing their job in the right amount.
Correct.
It's always this misconception that like germs are bad, bacteria is bad. No, germs are. I have germs on my germs. I have bacteria on my skin. I have bacteria in my gut. They help me digest and get proper nutrients. Antibiotics kill all those good and bad, mostly good
so
bacteria.
What you're saying is we need to change the term germaphobe to bad germaphobe.
I think it's. I tell my patients it's like infection is when a normal bacteria or normal. Well, bacterial infection is when a normal bacteria goes in the wrong place, and you've broken your immune system, you've broken your barrier in some way or shape, and then that bacteria like staph or strep, which is normally just like floating around on your skin and like kind of hanging out, and it enters into your bloodstream or crosses your skin, and then it causes a cellulitis or causes a bloodstream infection. Yeah, I'm not a germaphobe. They're good. They protect you from things like C. diff.
Okay.
They're important.
Do you guys want to hear something really interesting that I'm super excited to share with you?
Sure.
Yes. Guess what book I'm reading right now? It's called Blight. Have you ever read it?
Blight.
It's a book about fungus.
Oh, yeah.
Oh.
I'm reading about the future pandemic of fungus.
I've heard of those stories before.
Yeah. It's I think it was written in like 2022, and it talks about like good fungus, bad fungus, and what's actually happening around us with spores and everything. And I got halfway through the book. I'm completely terrified to finish it, but I'm too invested at this point. But anyway, I recommend it.
I will.
Blight.
Yeah, put it on
Blight.
put it on my reading list.
I'll pass it off to
There's
you.
very interesting theories about fungus, like
The Last of Us.
or I haven't seen that movie or TV show.
Oh dear. Okay.
It's called The Last
I
of
know
Us.
that there's zombie
Yeah.
fungus.
It's a movie called The Last of Us.
No, it's a TV series called The Last of Us.
It's based off a
It's
video
about
game,
fungus?
right?
It's based off a video game.
Yeah.
But Pedro, no, who's that?
Pedro Pascal.
Pedro Pascal.
Yeah. It's
is in
cordyceps,
it.
right?
Yeah, it's basically the zombie apocalypse due to fungus.
Oh.
It was big.
That's essentially what my book is sort of it's heading in that direction.
Yeah.
Yeah.
It's very funny.
Feels like.
There's this theory that the dinosaurs and stuff were that an asteroid had hit the Earth and then blocked out the sun. But then what actually killed the dinosaurs is that when you block out the sun, right, you created this dark environment and it's cooler.
And they love that.
And then
all
all this
about
fungus,
mold.
actually killed off the dinosaurs with fungal infections, which is possible. Yeah.
Oh, that's cool.
Yeah, it's interesting, right?
Well, I want to thank you guys for being here. This was surprisingly more exciting than I thought it was going to be.
Hey. What'd you expect?
I don't know. But this was really great. I learned a lot. Hopefully our listeners did too. And we're happy to bring you back for any seasonal virus.
Sure.
Yeah, we love seasonal viruses.
Yeah,
Keeps
I'm
us
a
in
big fan
business.
of
Sorry. Right.
flu.
Thank you guys for joining us.